and colleagues, I am Dr. Nair, Head Department of Cardiology at PRS Hospital, Trivandrum, Kerala. Today we bring you the last day, day 3's sum up of the heart failure meeting 2023 being held at Prague. Day 3 Prague saw a lot of new information and a lot of exciting developments that we could imbibe and take home too. To start off, we had the Titrate Heart Failure Registry. The Titrate Heart Failure Registry basically is a guideline implementation registry which tried to see if and how much the physicians are following the guideline implementation in the treatment of heart failure. For example, today we always advise that you need to simultaneously start the 4 heart failure drugs like the beta blocker, the MRA, SGLT inhibitors, and the ARNI, while traditionally the belief was that we go step by step. So what actually are we doing at ground level? So this was a large-scale prospective registry done at the Netherlands with heart failure and reduced ejection fraction. 4,000 consecutive patients, as you see there, were followed up for 3+ years. And what was looked into specifically was the order and speed of sequencing and looking at the long-term prognosis of how we treat these patients. Now, the important take-home points that we could get from this data set is that 25%, only 25%, got the standard triple GDMT, and only about 22% received all 4 guideline-directed medical therapy drugs at 28 days. So at 4 weeks, only about 22% of the patients received the standard 4-drug therapy. In about 35% patients, the physician started GDMT step by step, not all simultaneously as we advise in today's therapy and concept. Now, this is what was surprising. Now look at the data. This is the sequencing order that these physicians followed in this large number of patients. Okay, on the left you see the first drug chosen, the second line is second drug, third drug, and fourth drug, right? The sequence of drugs chosen. And the colors indicate each drug. ACE inhibitors and ARB or ARNI, RAS inhibitors are in blue, beta blockers in orange, MRA in green, and SGLTs in violet. Now you see that most physicians started their therapy with a RAS inhibition, ACE, ARB, or ARNI, that blue. That is the first choice in most cases. While the fourth choice in most cases is SGLT inhibitors, despite the huge amount of data supporting the use of SGLT inhibitors in heart failure. So what do we take from this registry? One, the most common first drug was RAS inhibitor, ACE, ARB, or ARNI. The fourth drug most commonly used is SGLT inhibitors. So we have to go a long way to cover, right? The Paradise data is the pathway of an acutely dyspneic patient in the emergency. So this is a common cardiac problem, right? Patients coming with acute onset dyspnea in the ER. Now this data comes from the Nancy University Hospital from France. Very interesting data. Look at that. All patients hospitalized after a visit to the emergency in Nancy University Hospital in France from January 2010 till December 31st, 2019, a 9-year period, covering about 18,900 patients. Right, so 18,000 patients from 2010 to 2019 coming with acute onset breathlessness. Okay, now what did we find? The data is very interesting. Look at the in-hospital mortality. So it's a very solid endpoint, right? We are looking at in-hospital mortality in different diseases. Look at that. There you see respiratory infection, for example, pneumonia. On the right, you see the set of COPD. At the bottom, you see asthma, pulmonary embolism, and others. And those bars indicate different age bands, right? Now, if in comparison, you look at acute heart failure on left top, you see the average in-hospital mortality is so different. One, of course, it is high. But interestingly, for example, if you look at pneumonia and respiratory infection, look at that age band. Yellow is less than 60, blue 60 to 80, orange more than 80. Look at that. There's a gradient. Obviously, younger people did better, while more people who were elder died. But in contrast, when you look at acute heart failure, look at that trajectory, the death rate was around 14-15%, whether it belonged to a 60-year-old group, 60 to 80, or more than 80. So acute heart failure has bad prognosis in every age band. So what did we learn from this data? Hospitalized patient for acute onset dyspnea presenting to the ED has a very high risk of in-hospital and post-discharge mortality, especially when the etiology is an acute heart failure. Right. Second, specialized units treating heart failure have a lower in-hospital mortality, especially when the etiology is acute heart failure. So this data very strongly suggests that we need to have a paradigm shift in the management of patients who present with acute onset dyspnea, right? Because only a minority of these patients hospitalized are treated in specialized units. So if they have an acute heart failure, they have bad outcome. We need to improve our delivery of care. The third interesting trial is the treatment according to left ventricular ejection fraction. We all know this was presented by Dr. Rossano. We all know that if we look into LV ejection fraction, 35, 40, 50, 60, right? We know that those who have that red square below 40 are HFref, right? Those who have an ejection fraction which is normal, more than 50 is HFpEF. And between the 40 and 50, the gray area, yellow here, is the heart failure with mildly reduced ejection fraction, which we used to call as mid-range ejection fraction, in the middle of HFref and HFpEF, right? Now we can have quite a few different trajectories of patients in the yellow zone. One, of course, they can continue to remain in the heart failure mildly reduced ejection fraction range. Second, they may actually deteriorate and migrate to HFref. Next, they might actually improve and go to normal ejection fraction. And that change might be either small, like what you see there, or large, what you see here. Okay. Or you might find a person who has a HFref now migrates, becomes better, to heart failure with mid-range ejection fraction, which we call as heart failure with improved ejection fraction, HF-IMP-EF, right? So their ejection fraction improves, and now they are from red to yellow. Okay, so many trajectories. But if we take out those data from DELIVER with dapagliflozin and EMPEROR preserved with empagliflozin, patients with preserved ejection fraction HFpEF, which includes anything above 40, includes the mid-range, we see that there is significant benefit by both DAPA and EMPA to a tune of 20% when we look into relative risk reduction of cardiovascular death and heart failure hospitalization. Similarly, if we look into reduction of cardiovascular death alone, it is 12%. So very significant gain by using empagliflozin and dapagliflozin, SGLT inhibitors, in this group of patients. So in conclusion, the study said heart failure and LV ejection fraction more than 40 represents a heterogeneous group. They can migrate anywhere. They can go bad, they can improve, they can remain same. Okay. Heart failure with improved ejection fraction, which also belongs to the mid-range or mildly reduced ejection fraction, does not differ from HFref. In heart failure with LV ejection fraction more than 40, SGLTs are very effective, and they should be started without delay in all patients of HFpEF. That includes the mid-range, the mildly reduced, and the true HFpEF. Ironman is a very interesting trial about effect of IV iron. This is their isomaltose iron preparation called their isomaltose. They looked into its effect in heart failure in different age bands. The clinical criteria, the clinical endpoint, the primary endpoint was death and heart failure hospitalization. It's interesting because most iron trials have shown only borderline benefits of symptoms and not hard endpoints. Now let's look into this data. Now this is HFrEF patients, 1137 patients, either randomized to ferric their isomaltose or control, and the primary endpoint was recurrent heart failure hospitalization and cardiovascular death. Look at the data. We find that a median follow-up of 2.7 years, there is a significant benefit of 25%, 24% in the group that received IV iron for iron deficiency. Now, a post-hoc analysis done at 12 months, because the curves separated early. So at 12 months, there's a difference of hazard ratio 0.66. So that 34% reduction of endpoints on giving iron in iron deficient patients of heart failure. And that is a lot, right? That perhaps pushes iron therapy from the fringe area to the mainstream of heart failure therapy. Now look at the data. Now, if you are looking at hemoglobin change, you see that yes, there is significant change of hemoglobin. Those who have been given ferric, their isomaltose in red bar compared to the blue bar in control. But what is interesting is here, if you look at the primary endpoint, which is cardiovascular death and heart failure hospitalization, and look at the age bands, you see even those who are more than 79 years, elderly, they benefited, right? See the control blue bar and the event rate in the red bar is significantly different. Red bar is significantly lower, which is even in the most elderly people. You give IV iron when there is iron deficiency, you benefit by a primary endpoint benefit of heart failure hospitalization reduction and reduction of death means more survival, right? And if you look into this data of cardiovascular mortality alone and look at the distribution of age, 60, 70, 80, more than 80, you see that the values are okay around about 10%, but they are the p-value is similar, which means similar degree of benefit, whatever be the age, right? So, what is the conclusion of this Ironman trial? There were a number of patients in this trial who were more than 80 years old, 79 years old, 285. And we see these older patients of heart failure and deficiency were more symptomatic, worse renal function, higher plasma NT-proBNP, and had lower hemoglobin, but similar ferritin and TSAT, right? And they had improved outcome. There's no attenuation of benefit in elderly patients. So I repeat, importantly, there's no attenuation of benefit in elderly patients. What about early diagnosis of heart failure? This is called the Peptide for Life initiative. Peptide for Life is what? NT-proBNP, right? So this is from Barcelona. This is just a concept that we always use NT-proBNP as a biomarker in acute heart failure, right? But this is changing. We are looking at biomarker NT-proBNP in non-acute heart failure in the community, people with left ventricular dysfunction with minimal symptoms, and even patients who are at risk of developing heart failure, the at-risk group, the diabetic, the hypertensive, the ischemic. And in all of them, perhaps the trajectory of NT-proBNP is important. So the take-home point was natriuretic peptides have hard scientific evidence, timely diagnosis, 80% diagnosed with heart failure following hospital admission. And natriuretic peptides have favorable effect on health outcome and cost. It is cost beneficial, right? And that brings us to an equally connected one where they looked into the heart failure. They looked into early heart failure, rule-in the ER. Okay, right. Now in this trial, they looked at 600 patients who came with an acute onset dyspnea. And clearly, the physicians in 1 of 3 were in doubt in patients who came with dyspnea. Is it bronchial asthma? Is it pulmonary embolism? Or is it an acute heart failure? And that is where the benefit of NT-proBNP comes in. Now, this beautiful graph was shown, which we are aware, but beautifully shown. For example, if you have an NT-proBNP of less than 300 picograms per ml, heart failure is unlikely. So the acutely dyspneic patient in ER, heart failure very unlikely if you have an NT-proBNP less than 300 picogram per ml. In contrast on the right, look at that. If you have an NT-proBNP which is more than 5,000 picograms, is very high risk heart failure. Admit, monitor in a specialized unit. If the patient has a clear elevation of NT-proBNP, not to 5,000 levels, but age 50 years, more than 450, 50 to 75, more than 900, more than 75,800 picograms, you have very clear heart failure, right? So admit and treat them as per the guidelines. And there still will be some patients who would be in the gray zone. So they would not be less than 300, between 300 and let's say 450. And there is a gray zone. Use your clinical judgment. Use alternative methods like imaging to diagnose and confirm heart failure. So evaluation dyspnea in ED is very challenging. Clinical uncertainty 1 in 3, and that is associated with worse prognosis. Natriuretic peptide testing, and coupled with imaging, gives us the proper diagnosis. So whenever possible, every patient with suspected or known heart failure should have an NT-proBNP. Because NT-proBNP is not just for diagnosis. It also tells them about prognosis and in-hospital monitoring. The last trial, before we end, is dapagliflozin in patients of heart failure. We know that dapagliflozin is effective in patients of heart failure, but what about association of peripheral vascular disease? Peripheral vascular disease. Now, this subset has never been looked into before. Look at that. DAPA-HF had less than 40% DF, NYHA224, elevated NT-proBNP. DELIVER had preserved ejection fraction, NYHA224, elevated NT-proBNP, but ejection fraction more than 40. And we know that dapagliflozin was given totally to this 11,000 patients compared to placebo, and the primary outcomes are worsening heart failure and cardiovascular death. Very clear, right? Now, when they looked into the status of the subset who had peripheral arterial disease, right? Look at that red, where there was no peripheral arterial disease. The dotted line is dapagliflozin, solid line is placebo. There was benefit. When there was peripheral arterial disease in blue, you see, yes, there is benefit. In fact, in peripheral vascular disease, actually, you see there's some more benefit of about 29% compared to 20% when there's no PAD. But this is not a comparison. Basically, both groups, PAD or no PAD, they benefited with dapagliflozin. Right. Now, one question is about amputation. Why amputation? Because in Canvas trial, we know that there has been slightly increased incidence of amputation. So many physicians are skeptic or careful while writing dapagliflozin or any SGLT inhibitor in the background of a gross significant peripheral vascular disease. In that ischemic background, will there be more lower limb amputations? Now, in this data set, very clearly, peripheral arterial disease, no peripheral arterial disease, amputations were not different at all. So this data takes away the myth that one has to be careful in patients of peripheral vascular disease in prescribing SGLT inhibitors. Dapagliflozin is safe for peripheral vascular disease. So what did we learn? In this particular trial, dapagliflozin reduced the risk of adverse clinical outcome in patients with and without peripheral vascular disease. Dapagliflozin symptoms and quality of life in both improved in both patients with and without PAD. Dapagliflozin was safe and well tolerated. And lastly, dapagliflozin did not increase the risk of lower limb amputations. Right. So with that, goodbye from Prague, and 2024, we await you at Lisbon. Thank you for your time and attention.